Good evening or good afternoon or morning. Good day, everyone, wherever you are. And welcome everyone again to the BOMS Journal Club, which is very well already famous now. Amazing content and discussions. And I'm Chetan Parmar. I'm one of the bariatric consultants in London, and I'm chairing the session today along with Emma Shuttlewood. And we have the excellent team from Luton who are going to talk about a couple of papers, and I'll hand over to Emma to introduce them and begin the session. Welcome, everyone. And put your Q&As as the session goes, and we will be looking at them while the discussion is going on. Thank you. Over to you, Emma.
Thank you, Chetan. Thank you. So yes, we've got some really interesting papers tonight. So we're going to start with Debbie Musandiki, who's a clinical nurse specialist, and she's going to be talking about a paper looking at quality of life and depression levels in a really interesting long-term study that we don't often get. So just as Chetan said, please do put your questions in the Q&A or the chat, and we will ask them at the end. We've got about 14 minutes for presentation and then 6 minutes for chat, and then we'll hand over to the surgical paper. All right, Debbie, over to you. Thank you.
Thank you. Just sharing my screen. Could you confirm that you can see it?
Something's happening. There we go.
Yeah.
Yep.
We can.
Okay, so good evening, everybody. As already discussed, my name is Debbie, and the paper I'm presenting today is quite interesting in so many ways. I hope that we raise some interesting discussions afterwards. So just to give you a bit of background, they were monitoring changes in mood and health related, and this was done by Look Ahead, and it is a very long study, and it just was recently finished in just before COVID started, actually in 2019, so a fairly recent paper. And they had a really good participants, and just to give you some of the information that you're already aware of, the reasons why this was done is because Look Ahead realized that people with type 2 diabetes are at risk of depression and impaired quality of health. And so we know very well, obviously, that weight management is a recommended treatment for this cohort of people. So they did a study where they had 5,145 participants, both men and female. I'm just going to go back to that. Men and female, and they had an inclusion criteria, which was fairly straightforward. And they divided the groups into two. One had intensive lifestyle changes, and another, the control group offered diabetic education support group. And they wanted, so the study prior to the paper that I'm presenting was done for 10 years. And the results from that was the first 2 years or so, participants had 15% weight loss reduction. And then after that, there was no statistical differences. So the study was discontinued. By the way, this was a randomized controlled study. So this paper that I'm presenting today, they then looked at the effects or the differences between these two groups post the interventions was stopped. So again, those are just to show the results the first few years. The first study was about 10 years. And then the study that we're looking at today looked at 6 years post intervention. They looked at different variables. I'm just going to go back. They looked at depression. So they assessed depression, they assessed physical activity. So that's managed by the PCS and the MCS scores. And they used various tools to achieve this. They used a PHQ-9 and a DBI tools to assess for depression. And also, again, in these studies, it shows that there was the first years where there was a lot of intervention, there was very low scores in depression and medical conditions. I'm not sure why this study chose to change from one psychological tool to another. But as you can see from these results, there was not much differences between the two groups in their PHQ-9 levels. So just to say how they did this, the participants were being seen quite regularly the first 2 years, and that's probably why there was so much weight loss. And thereafter, they were seen after 7 months to the next 12 months, they were seen once every year, once, and then offered a group session. So the method was quite varied and inconsistent. Just to jump onto a little, some of the things that I found interesting, that after the 6 years of their study, they found out that there was no statistical differences in physical activities. There was no difference in depression levels. And also, I didn't mention this, but the study included quite a wide variety of ethnic backgrounds. And again, there was no differences between these. However, they did notice that there was a higher depression amongst women. That was about 60% of them. So there's a few issues for us to discuss here. What I found is that obviously the strength of the paper is that the longevity, the long time they were looking following these people is quite credible. But the cohort, they were looking at the age group between 45 to 76. So it's quite an older cohort. And I wonder if the results had been different had they chosen a younger cohort. Obviously, we are aware that with that age group, comorbidities are quite significant, and whether this had any skewed result, I'm not sure. So that's another point of discussion. And their conclusion was that in the older ages, there is need for ongoing support. And I suppose in our clinical areas, maybe this is something that we ought to be looking at. Are we offering that age group enough support going forward? They also used, I'm not sure why, like I said, about the different tools to assess depression, but as far as I'm concerned, the DBI is more thorough than the PHQ-9, and I think that also it's not a true reflection of where one stands when the PHQ-9 sort of asks you questions about your mood within a settled time frame. So if they were seeing these patients over 12-month period, then I don't know if that was an adequate tool to use. Another tool they used to assess depression was the antidepressant medications. Again, we know that a lot of people who are depressed are not necessarily taking medications. So again, that, I don't know, I think that would have been not accurate to use. However, looking into our clinical areas, what I thought was interesting is that they were doing virtual contacts with these patients, and this was prior to COVID. And I wonder if we're doing enough now in our clinical areas in terms of support during COVID, when we're offering virtual support systems. This cohort of patients were already struggling prior, and and there wasn't much results. And I'm just wondering as clinicians, are we doing enough? Are we catering for, is virtual clinics enough for us? Is there more work that needs to be done in that area? So I suppose it's a point of discussion. Thank you.
Brilliant. Thank you, Lee. Thank you so much. I must say, yeah, I was reading this paper earlier, and it's really complex, and it was quite hard to get your head around, because they did this as a kind of retrospective observational study, didn't they, off a bigger study?
Yes.
And what I found quite interesting is the participants for this study, or their average age was 75.
Yeah.
Quite an older cohort. So I was thinking about that in terms of our patients that we see clinically. And also actually the incidence of sort of clinical significant levels of depression for their study was around 2%.
Yeah.
Which is actually far lower than kind of the national. So this is an American study, so it's generally around 7 to 10% in the general population. So obviously they actually had a cohort of patients that were a lot less depressed than the sort of general public, which is quite interesting given that they were type 2 diabetes.
Absolutely.
Yeah, it was really interesting. And so whether that is also why you didn't see a great effect with time. The other thing I noticed, I don't know whether you thought, Debbie, they didn't comment, or maybe I might have missed it, so please tell me if I missed it when I skim read it earlier. They didn't comment on whether people had any psychological intervention.
I found that as well quite interesting. They didn't comment whether the phone calls they were making and the group sessions were actually psychological in there. What they did offer was a dietary support, where they gave a restricted calorie intake as well as prescribed physical activities. But in terms of psychological support, there is no mention of that.
No, there's none. And what was quite interesting as well is the levels of antidepressant medication. So about 25% of participants were on antidepressant medication, compared with actually only less than 2% that were actually diagnosed with depression. So you've got to kind of wonder what's going on there. Why is there nearly a quarter of the participants on medications, yet they've not reporting having depression? Whether it's because the meds are working, I suppose.
Maybe.
Yeah. But yeah, really interesting. I mean, if you think about, because it was a study on type 2 diabetes, wasn't it? How do you think that relates to the bariatric services? Is there anything, I'm putting you on the spot, sorry, Debbie. Is there
No, it's absolutely fine.
What do you think we can take away from this as a bariatric sort of services? And
again, when we look at that cohort of people, it's almost because of the age, we do get old age onset diabetes, don't we? So again, it's not a true reflection, but we know as a fact that obesity and diabetes go hand in hand, and we do need to look more into that. Into the fact, and also the fact that if it's a cohort of older people, they don't necessarily go outside for physical activities, which would increase their well-being. I'm not sure about that age of cohort, but within our bariatrics, that's an area that we really need to focus on.
Yeah, no, I think you're absolutely right. There's no upper age limit, really, isn't it? It's about quality of life and how much they can sort of make use of the outcome from surgery, isn't it? So yeah, no, I agree. I used to work at type 2 diabetes, and there's so much overlap in these populations. So I think it's really good to look at the literature that's in the type 2 diabetes world. Chetan, did you want to we have had one question, I think. Is there anything you want to add to?
Yes, thanks, Debbie, for the excellent summary of that. I think one question from me before I go to the question from the audience was, I know in this paper they have not touched, in our tier 3 and in some centers, majority of the patients also get a bit of a psychological assessment and support. Would that make a difference, you think, or would you, in your preference, say they all should have that counseling or a session before or as a part of the workup of bariatric pathway? What do you think?
Absolutely. I think that psychology should be not negotiable. I think that our patients do need that psychological support. We know that 90% of our patients, the problems they have with their extra weight is not because they have no willpower, but there's a lot of psychological issues going in the background. It's a lot of trauma. It's a lot of self-hate. It's a majority of it is psychological, and that needs to be addressed. Even body dysmorphia, that needs to be addressed psychologically. So if we just tackle the weight just purely by bariatric surgery, you're not curing the root cause of the problem.
I would just like to point out that I have not paid Debbie to say that. Obviously, as a psychologist, I am in complete agreement. We need to look at the whole picture. And I think, again, that's probably where there's a lot of similarity as well with type 2 diabetes and obesity weight management, is I suppose there's so much shame and stigma in it, isn't there? There's a sense that you've caused yourself to have type 2 diabetes, or, you know, you've brought it about yourself, and that's the same often how people feel. It's not true, but that's kind of a perception, or that's what people think. So I think that's often as well where, yeah, kind of that's when people can get in really unhelpful negative cycles, because exactly as you said, they've got a lot of self-hate or self-criticism going on. There's so much shame and stigma in the world that they live in. So yeah. Okay, should we?
So the question from an audience, it's more of a personal question. They say, in your years of experience, which approach do you find patients respond to best, intensive or non-intensive?
Intensive, especially when we're dealing with patients carrying extra weight. I know as clinicians, it's very easy for us to take the parent and child role, and we want to tell them what to do. But our patient cohort actually needs a lot of motivation. They need that cheering and just walking alongside them to make sure that they meet their targets. So definitely intensive. If they could do it by themselves, they would have done it a long time ago.
Yeah, it's interesting. I mean, at the end of the day, you know, type 2 diabetes, weight management, we're talking about lifelong issues. These are never fixed. They're never solved. So I appreciate there's a pressure in terms of finances and money, and I get that. And it's a really hard balance to find. But yeah, I think because the other bit, I mean, coming back to the study in a way, and they sort of breezed over it in the discussion. But actually, I suspect that anybody that had really high levels of depression either didn't participate in the study or dropped out pretty early on, and they didn't really talk about what lengths they went to engage a patient population. You know, this study was on depression. You want to try and engage those people who were at massive risk of dropping out of any kind of treatment, research or clinical. So yeah, I think it requires quite intensive work at times. But yeah, really interesting, Debbie. Thank you.
Thank you.
Good. Thank you, Debbie. And I think
you.
Close your session. And now we would like to invite, there you go, Chanprit Arhi is appearing. So now we would like to invite Chanprit Arhi. He is one of the bariatric fellows at Luton. And welcome, Chanprit. And he is going to talk about long versus short biliopancreatic limb in Roux-en-Y gastric bypass, short-term results from a randomized controlled trial from SWORD paper published in March this year. Chanprit, stage is yours.
Hi, good evening, everyone. Thank you to the BOMS Journal Club for giving us the opportunity. As Chetan has just said, this is the name of the study that I'll be discussing today. This was published here in April 2021 in the Surgery for Obesity and Related Diseases. The impact factor for this particular journal is 4.7, which is relatively high for a surgery-specific journal. When you're looking at the level of evidence, it's either going to be a 1B for a very well designed randomized controlled trial, or 2B, and I'll come back to that in a bit. So how do we come across this paper? Well, we can use the PICO model and say, in adults with obesity undergoing laparoscopic Roux-en-Y gastric bypass, does a longer length of biliary limb compared to a shorter length of biliary limb improve weight loss as a primary outcome? A secondary outcome could be resolution of comorbidities. Another reason that we might look at this paper, or another thing that we might think about while reading this paper, is as a bariatric surgeon, would I change my practice by lengthening the biliary limb during a Roux-en-Y gastric bypass to improve weight loss and or comorbidities, but at what cost would this, if we were to do this? And does this paper, if anything, add to our current knowledge about the BPL? So a bit of background, we know what the Roux-en-Y gastric bypass is. And I would suggest majority of surgeons will choose an alimentary limb between 50 and 150 centimeters and a biliary limb between 50 and 150 centimeters. Also, the majority of surgeons probably don't measure the common channel, except for when it does come to these trials. How does the bypass work? There's various different hypotheses, and it's too detailed and too complex to go into it right now. But if I split the main two hypotheses, the hindgut hypothesis, which suggests that the fast delivery of food into the distal ileum makes an effect, and you get the foregut hypothesis, where you bypass a certain length of jejunum to also have an effect on the hormones. And these can be either bile acid mediated, or there may be an increase in GLP-1 and PYY. What do we know about this already? Well, the importance of the biliopancreatic limb was looked at in this systematic review in 2019. And what they found was lengthening the biliopancreatic limb does make a difference. It does improve comorbidities and weight loss. They included 13 studies altogether, of which 6 were randomized controlled trials. But even within the randomized controlled trials, there was a variation in the biliopancreatic limb, but also the alimentary limb was changed as well. So it's difficult to tell which one was making the difference. And another review from 2018, which looked at the alimentary limb, found that if you consider 100 centimeters, around 100 centimeters being the standard alimentary limb, if you compare that to an alimentary limb of over 150 centimeters, you don't get any added benefit in weight loss or comorbidities. But if you reduce the alimentary limb to 50 centimeters or less, you'll find that the weight loss isn't so great. But again, there is variation in the biliary limb when these alimentary limbs were changed. So in this particular study, this was a single center study from the obesity clinic at the Hospital General Toluca in Mexico City, which is an academic unit. The primary author was Carlos Zoek, who's a bariatric surgeon, has got a number of publications. It was a randomized controlled trial where patients were recruited between January 2016 and January 2018. On the left here, you can see what their standard practice was, and that is a biliary limb of 50 centimeters and an alimentary limb of 150 centimeters. And they didn't routinely measure the common channel. And then they moved over towards this is the cases on the right-hand side. And so what they did for this study is extended the biliary limb to 200 centimeters, but shortened the alimentary limb to 50 centimeters. And again, it doesn't seem like as if they routinely, or they did not measure the common channel. And in the author's own words, the reason the BPL of 200 centimeters was chosen for the case group to mimic the OAGB. And I'll come back to that again towards the end. So the inclusion criteria was a BMI of over 35 with at least one comorbidity, a BMI of over 40 with no comorbidities, and the patients were seen pre-op by a dietitian, psychologist, and an endocrinologist. The exclusion criteria was reasonable, a BMI of less than 35 or over 60. If the patient was having a revisional surgery, the bypass was a revisional procedure. It was incomplete data, or the patient was not willing to participate. So patients were randomly assigned one to one to each group. It wasn't clear exactly how this was done. The primary outcome was weight related, so percentage excess weight loss and percentage total weight loss at 6 and 12 months. The secondary outcomes were resolution of diabetes with an HbA1c of less than 6% and not on medication, and resolution of hypertension, less than 120 over 80 and not on medication. There was also some other blood tests carried out listed here, including the C-peptide, serum glucose, and they also looked at complications, although it was unclear exactly what time period post-op did they include the complications. The surgical technique they described as standardized between 3 surgeons, and there was 30 to 50 ml pouch created, an anti-colic configuration. They used the staplers to make the anastomoses, and both the Peterson and mesenteric defects were closed. They also used a 10 centimeter marker on a grasper as a way to measure the different limbs. So when we look at the results, 210 patients were included and 105 were allocated to each group. They lost some patients at 6 months and they lost a further few patients at 12 months. So by the end of 1 year, they had 96 patients in the long biliopancreatic limb group and 94 patients in the short biliopancreatic limb group. So fairly similar, and around 90% of patients managed it to, they had 90% of patients' data at the end of 1 year. When we're looking at the baseline data, what we find is that there isn't really much difference, as you would expect, between the two groups in all these different demographics, including the BMI of around 43, a weight of around 116 kilograms. There are some differences. I'm not entirely sure that they make much difference. The height, slightly taller patients in the long biliopancreatic limb group. There was a higher proportion of patients who had a lower HDL in the long biliopancreatic limb group. And just to highlight here that the proportion of patients with hypertension and type 2 diabetes was similar between both groups. About 40% were diabetic in the short group, and 36% were diabetic in the long biliopancreatic group. Now, when we're looking at the weight loss, this graph here demonstrates the weight loss both at 6 and at 12 months, and looking at both the excess weight loss and the total weight loss. If you look at these, at the top two lines together, with the solid line being the standard gastric, the short gastric bypass, and the dotted line being the long biliopancreatic limb, you find at 6 months there was no significant difference either in the excess weight loss or the total weight loss. However, when you get to 12 months, we find that there is a significant difference where the long biliopancreatic limb provides around 84% weight loss compared to around 78% weight loss for the shorter limb patients. When we're looking at the total weight loss, there's about a 37% total weight loss compared to a 34% total weight loss for the shorter biliopancreatic limb. Looking at the comorbidities, diabetes remission and both hypertension remission, as per their criteria, there was no significant difference. Although in the long biliopancreatic limb, there was a tendency for higher levels of remission, close to 80%. Now, this graph and this table, I'm just going to try to break this graph, this table down to make it easier to understand. So here, what these two columns describe with these red boxes around them is that there was a significant change from baseline to 12 months for each of these procedures for the majority of these measurements, these outcomes, except for perhaps the serum albumin, with which there was no significant difference after 12 months for either group. When you're looking at this red column here, this describes the difference in baseline. And as I mentioned before, there was a difference in the HDL between the two groups, with lower HDL in the long biliopancreatic limb. And when you get to this result here, which is now comparing the results at 12 months, again, there doesn't seem to be much difference between any of these parameters, whether it's cholesterol, protein levels, type 2 diabetic treatment. However, there is a difference in the HbA1c, where for the short biliopancreatic limb, it was 5.4, and it was significantly lower for the long biliopancreatic limb at 5.2. Looking at complications, again, not much difference between the two groups. I've just highlighted a few here. The operative time was slightly longer for the long biliopancreatic loop, but I mean, to be honest, not much difference. Leak rate was around 2 to 3% in both groups, no significant difference. One thing to note, though, there was one patient in the long biliopancreatic limb group who needed a reoperation and shortening of the biliopancreatic limb because of severe malnutrition. So the authors, this is their own conclusions I've highlighted here. So it's lengthening of the BPL limb achieves highest benefits on weight loss at 12 months. Mid and long-term impact is still in question. The long biliopancreatic limb gastric bypass advantages related to comorbidities is modest. The limitations are that the short-term, small number of patients and a lack of complete bowel count and complete nutritional profile, including vitamins, is lacking. So when I tried to critically appraise this paper, I looked at both the internal validity, so that's suggesting how reliable are the results, and in a bit I'll discuss the external validity to see whether or not we can relate this to our own population and our own practice. So I would say the selection bias is unclear. The groups were similar, they were randomized, but it's unclear exactly how they were randomized, whether or not all consecutive patients who walked through the door were randomized or how the allocation was assigned once they were randomized. The other issue I have with this paper is the high risk of bias related to performance bias. So obviously surgeon blinding is not possible, but could other members of the MDT be blinded? And even the patient could have been blinded themselves to what length of BPL limb they received. How were the measurements of the bowel ensured to be accurate? It was unclear whether or not there was any videos taken, if another surgeon was looking back to ensure that the quality was standardized. And the key thing for me is that the alimentary limb was varied. So if you vary the alimentary limb as well as the BPL limb, you're going to have differences in the common channel, and that's quite an important confounder, which hasn't been which they've said is a limitation, but put some doubt to the results. We know that short alimentary limb gives poorer results, and I believe the authors are unable to keep the alimentary limb at 150 centimeters, because if they had done and also extended their biliary limb to 200 centimeters as they did, then you'll have altogether 350 centimeters of bowel, which is not part of the common channel. And as we know with OAGB, if you reach 200 centimeters and beyond, you're going to be causing malnutrition and quite severe problems for the patients. And for this reason also, I don't really reckon this replicates OAGB or can be compared directly. Looking at other factors, the attrition bias, so 90% of patients were followed up at 1 year. This is equal in both groups, but it's unclear what the differences were between the dropouts and those that remained. There was no intention to treat analysis, so ideally all patients should be included as the denominator at the end. When it comes to reporting, the initial outcomes, which were weight loss and comorbidities, were reported, so that's good. But there's no difference, and there was also no difference in the reporting between the two groups, which is great. But there are other ways to describe differences, such as absolute differences with 95% confidence intervals, which wasn't provided within this study. When you're looking at external validity, the criteria of inclusion is similar to NICE, so that is relevant to the patients that we see on a daily basis. I'm not entirely sure the preoperative workup, so there was an MDT discussions, but whether or not tier 3 equivalent was involved. There may have been differences in ethnicity, but I would suggest the basic demographics are fairly similar. The BMI was around 44. I think in Luton, quite a few of our patients are closer to BMI of 50. There are some differences in the operation. So the standard operation at Luton is usually a BPL limb of 60 and an alimentary limb of around 120 centimeters. And the complications were relatively low and probably at the level that we would expect. The other factors to consider is that I couldn't see anywhere any sample size calculations to suggest why they came to the 105 and 210 patients altogether. And this would have given a bit more confidence to say that there was enough power in the study to look for complications, to look for the weight loss and the comorbidities. I think it's important now for every randomized controlled trial when it comes to bariatric surgery to include quality of life assessments, because even though one patient had malnutrition bad enough to have a shortening of the BPL limb, I'd like to know for the rest of the patients what their quality of life was like. Were they having a lot of diarrhea? Were they having any problems with a long biliary pancreatic limb? There's other comorbidities, maybe not metabolic, such as asthma and obstructive sleep apnea, which would have been interesting to look at. And obviously, as the authors suggested, this is just a 1 year follow-up at the moment. Long-term outcomes are needed before any firm decisions can be made. So going back in conclusion to the PICO model, in adults with obesity undergoing Roux-en-Y gastric bypass, does a longer length of biliary limb compared to shorter length of biliary limb improve weight loss or resolution comorbidities? I would say this study says maybe, because we don't have, because the change in the alimentary limb makes it difficult to make any firm conclusions. As a bariatric surgeon, would I change my practice by lengthening the biliary limb during a Roux-en-Y gastric bypass? I would suggest no, not based on the studies not based on the results of this particular study. And does this add to our current knowledge? Well, it does. We already know we could expect some of the results from that review that I mentioned. I believe, well, we know about the long limb trial carried out in combination with Imperial, King's College and a few other centers, which has found that keep the alimentary limb at 100 centimeters and changing length in BPL limb doesn't make any difference, which gives us a bit more information regarding this. So I'd say overall, the level of evidence in this particular study is around a 2B. And I think it's answering a very relevant question, but in essence, I think it could have been designed better. Thank you.
Thank you very much, Chanpit, for an excellent summary and detailed analysis of the paper. To be honest, I was jotting down a couple of questions, and then you immediately in the next slide tended to already answer my questions. So it was a bit tricky to come up, and I assume the audience has the same issue here, Chanpit. Anyway, while they are thinking, I have a quick question here. One was, well, you have a positive comment there, excellent critical appraisal from Richard. as you rightly mentioned, I think the BP and the elementary limb total is different, because in the standard it is 150 and 50, which is 200 total, whereas in the case series study group it was 250.
Yeah.
There, so it's 250. So you can't really compare that, and that is, and you rightly said that they were trying to compare it with OAGB as well. So you can't compare, because here it's 200 and 250. Agree. You mentioned that probably, so my question was going to be, would you change your practice? But you already said no. But further going in depth, as we know that when you increase the BP limb, it adds to that hormonal side of it, things as well, with the insulin, GLP-1 and stuff. And this paper did show that not great, but you did say that I think in the standard group, the HbA1c improved to 5.4, whereas in the other one, there was a bit significantly better. Would you offer this then to your diabetic cohort?
So I'd say, like I said, I mean, when I'm looking at just this paper, it's difficult to make any firm conclusions. However, there is some body of evidence which shows that a longer BPL limb may be beneficial for the diabetic patients. We have, like I just mentioned briefly at the end, is the long limb trial where they've kept the alimentary limb the same and lengthened the biliary pancreatic limb, and found actually there was no difference between the two groups when it comes to those diabetic related. So I know there is that theoretical benefit of extending the BPL limb. I think we've seen in some animal models. We've also seen in some patients as well where lengthening it makes a difference. But I think until we have a standardized way of carrying out this trial where we have the alimentary limb, the biliary limb, and the common channel measured, and then we look at outcomes and look at 1 year, 2 years, 3 years, then you can make a firm conclusion. If you're asking me what I would do now, I think what I've learned from various different centers that I've worked in, that there is that general consensus by extending the biliary pancreatic limb for diabetic patients. Whether or not that's because the common channel shortening, or whether it's not because the biliary pancreatic limb is lengthening, is difficult to say. But I think at the moment, my practice would be actually still be to lengthen that biliary pancreatic limb, because it does seem to make a difference. Where exactly and why it makes a difference, I don't know. I don't think we know yet.
Okay, thank you. And
we
I think that there is a question. Yes, Emma, go on with the question.
No, I was gonna say, yeah, we've had a question. Although again, Chanpreet, you're so incredibly thorough. I think you may have answered it. So we had a question from Ravi Krishna saying, anecdotally, surgeons alter BP length for diabetics and/or BMIs over 50. Would you recommend it?
Yeah, like I said, I would say yes. You probably would, but if you're asking me which one is making a difference, the BPL limb being longer or the common channel being shorter, that's the difficult question. So I think, yeah, I would probably extend it. I wouldn't go say 200, like they did 200 centimeters. I think that's a bit extreme. But yeah, I would probably lengthen that BPL limb with the knowledge that we have at the moment.
And would you, the other part of the question, would you do along with diabetic, would you, if it was a 55 BMI patient with non-diabetic, would you alter your BP limb in that cohort? That was the other part of the question.
Yeah, because I think there is some evidence to suggest a difference there, because it seems like the weight loss is better with the longer biliary pancreatic limbs. We can see it within the reviews. We can see it within this study as well. But the underlying issue is still the same. We don't know what exactly is causing it, but yeah, you could lengthen that as well. I would lengthen it for the higher BMIs.
The other interesting thing what I noticed was that, we are often criticized when you go with a longer BP limb. Mainly you were trying to, even the authors were trying to quote or mimic OAGB, that when you go 200 centimeter limb length, you get malnutrition. Whereas here, near 100 patient, you didn't really see a significant difference in the malnutrition. Then the other question would be, in that cohort, would you rather just offer OAGB with a 200 centimeter limb, or would you do Roux-en-Y with 200 BP limb and 50 elementary?
I think there's other questions to be answered between whether or not you go Roux-en-Y gastric bypass or single anastomosis gastric bypass. But if I was to choose between the OAGB 150 centimeters or what they did within their cases, I would suggest 150 centimeter OAGB would be a better option. The malnutrition, even though the malnutrition levels weren't high, there was only one patient that had a reoperation. And like I said, there's no information provided regarding whether or not they were having diarrhea, abdominal pain, all these other issues that you might worry about with a longer biliopancreatic limb. So I think that's an important thing to keep in mind.
I think I agree that, not mentioning about the micronutrients and all, which are always a concern with a longer BP limb. I think that is one of the drawbacks that I agree with you. While we are doing that, another question, Chanprit, so they used in their case series 50 centimeter alimentary limb, and we know that the reason why people tend to use longer alimentary limb is to prevent reflux. And have they commented? I don't know. I don't think you mentioned that, but have they commented anything about reflux, hiatus hernia, PPIUs, OGD,
No.
anything?
No mention of that. I mean, again, it's one of those things which I didn't put down. It's something that I definitely agree with you, Chetan, is that if the 50 centimeters is a little bit on the shorter side, and it will be good to know whether or not those particular patients had reflux symptoms, but there's no mention, or whether or not any patients had a hiatus hernia repair at the time of the procedure.
Okay, I'm trying to look. If there are more compliments coming rather than question.
We've had a couple. Mary O'Kane, yes, has said it was a really great presentation and really great to see you drawing attention to the lack of nutritional parameters being measured there, because I know that this is something she's particularly interested in. We were speaking about at BOMS, and just another compliment really from Gwen, saying an excellent presentation on bypass length. So yeah, fantastic, Chanprit. I think I finally begin to understand what they're talking about now as well. I find it really helpful and educational. I've heard about these things, but obviously as a psychologist, I didn't quite get what they're talking about, but those pictures were great. I feel like I've really begun to understand it. So thank you so much.
I can't take any credit. I didn't really draw those pictures. I can show you where I found them though.
No, but you included them and explained it really well. So no, yeah, thank you.
And I think your other main point was about the quality of life. That I think I agree that there was no mention of quality of life, and I think we have enough evidence there. And I think future is that along with all this, we do publish quality of life results as well, because that does make things important. As you rightly mentioned, there was no mention of whether patients had diarrhea, abdominal pain, frequency of stool. You would expect with a, if they are trying to mimic that with OAGB, those are the common questions which come, isn't it? So
yeah, no, absolutely. I think I don't think we can do randomized controlled trials now, proper randomized controlled trials, without having quality of life assessment, whatever they might be, whichever type of surgery you're looking at. I think it's very important for all patients.
Yeah, I absolutely.
And I think we'll wait for 2 years and 5 year result with this cohort. That might be the best thing now. Good, fantastic.
Could I so that was absolutely great. So obviously huge thanks to Luton for presenting this month. As a reminder to all those who are attending today, there is an educational webinar which is planned for in 2 weeks' time, for the 25th of August. We're just sort of firming up the title for that, so I'm afraid I can't give it to you tonight. Also, there will be, the next journal club will be the 8th of September, so Wednesday the 8th. So please put those in the diary, 8 p.m. as usual. Wear your jammies, have a glass of wine, you won't be seen. So yeah, please make sure that you register and sign up to those. But thank you all who attended tonight.
Thank you again, Debbie. Thank you, Chanprit. Thank you all the people who logged in on evening to spend this 45 minutes with us. Thank you again, BOMS, and thank you the sponsors, Novartis, for sponsoring this journal club. Have a nice evening, all of you, and see you next time. Bye-bye.